So our session today was focused primarily on immune aplastic anemia, and it's really broken down into two main themes. The first was clonal evolution. So that's when patients who have initially aplastic anemia later can develop myelodysplastic syndrome, or PNH. And then the second major theme was about some of the newer therapies that are up and coming. So just to summarize the initial couple of talks, which were both about clonal evolution, my colleague Dr. Patel at the NIH summarized some of our work looking at somatic mutations. So these are genetic changes that we sometimes see in patients with aplastic anemia. And this was first noted really about 10 years ago now, but we're still learning what these genetic changes mean for patients. So what we found more recently is that there's certain genetic changes which are associated with progression to myelodysplastic syndrome, and depending on when these genetic changes are found and which specific ones they are, they may accumulate further ones, and these are the patients that really seem to be at higher risk of developing MDS. So I think for patients what that means is if you have a genetic test and it shows up that there's a genetic mutation, that this may have some prognostic implications. And for most physicians, we may increase the frequency of your monitoring, so that may include more blood tests, more frequent bone marrows, or if there's certain really high-risk genetic mutations, it may be something where we say, well, actually, if we're between two therapies, so giving more immunosuppressive therapy or doing a bone marrow transplant, that because the risk of MDS is higher, we might consider doing the bone marrow transplant. The second session was Dr. Pedro Prada. So he was talking about studies that have been done looking at patients who had a bone marrow transplant who initially had aplastic anemia and then they later developed MDS. So we know that when this happens, this has traditionally been thought of as a very, high-risk MDS with a high risk of death. And really transplant has traditionally been thought to be the best way to treat this. So he conducted a study with the EBMT, so that's the European Bone Marrow Transplant Group, and they looked at all the bone marrow transplants in Europe that had been done in patients who had the secondary MDS after aplastic anemia. And they found that actually the overall survival was better than had been previously reported, so around maybe 60 to 70% after transplant. And we also had a lot of discussion about the specific regimen that we would use in transplant, whether we would use a very high intensity regimen, which is called myeloablative, versus a lower intensity regimen, which is called reduced intensity. And I think the consensus with a lot of the expert discussion was that we don't really have data on this yet to know definitively, but that probably most patients that are being treated with the lower intensity regimens, and that this seems to be sufficient, unless they have particularly high-risk features, which are having increased like leukemia cells in the bone marrow or having more cellularity in the bone marrow. So these are the kind of things that your physicians will be considering if you end up needing a transplant and we're deciding, which specific conditioning regimen we're going to be using. The next talk was regarding avatrombopag in aplastic anemia. So this is a drug similar to L-trombopag, which is currently licensed in the US, but this is not licensed globally, and there are other similar medications that are used in other countries. For example, they use a drug called romiplastim, so that is available in the US, but it's not licensed for aplastic anemia. They use that a lot more in Asia. And this is an Australian study which was using avatrombopag, which has been licensed in immune thrombocytopenia, but not yet in aplastic anemia. And it's really quite similar. It's a medication that you take it twice a day. A couple of things that are different to L-trombopag. So if you've ever taken it, you'll know that there's a dietary restriction with L-trombopag where you have to take it on an empty stomach and you can't take things with calcium, so that's not a problem with avatrombopag. And the other thing is that L-trombopag can cause liver problems, and sometimes patients have had to hold doses, so this is not a problem with avatrombopag. And in the Australian study, they've basically shown that it's pretty equivalent in terms of response to L-trombopag, so it didn't seem to be that different. So this is a therapy that is being investigated further and may become available in the future once this trial is formally reported. And then the final thing was a talk on T regulatory cells. So these are immune cells that can be infused into patients. So this is a type of cell therapy, and it's coming from umbilical cord. So when you have a baby, the cord will have these cells in it, and these can be taken out and expanded and infused into patients. Because we know patients with aplastic anemia have an immune system that is not regulated properly. So these are kind of regulating lymphocytes. And this is a study, it only had 4 patients with aplastic anemia, but it's really been the first trial looking at cell therapy and aplastic anemia. And they found in 3 of those patients, they had some sort of response to this. I think the big thing for patients to know is that there is a bigger trial being developed, which will be multi-center, and this will hopefully be in the next year or 2, and it's mainly being developed out of MD Anderson. As we know, there's 2 main modalities that we use in aplastic anemia. One is immunosuppressive therapy, and one is bone marrow transplant. So I think in terms of bone marrow transplant, one of the big breaks in the past couple of years has been reporting of really good outcomes in haploidentical transplant. So these are transplants from half-matched donors. And the importance here is that this really opens up the donor pool. So in the past, many patients would not have a good donor, because if you were relying just on a matched sibling, you have a 1 in 4 chance, and a matched unrelated donor really varies by your ethnicity. So there's a lot of patients who don't have donors if that's what you're restricting to. But if you open up the pool to haploidentical donors, you're much more likely to get one, because that includes parents, children, and other relatives that could be potential donors. So there's been a lot of promising work in that done, particularly out of Johns Hopkins. So I think that's a very promising thing for patients who previously did not have a bone marrow transplant option. In terms of immunosuppressive therapy, I think the standard of care now is horse AGD cyclosporin L-trombopag. Something we're working on at the NIH that I think is pretty cool is that we know that patients with aplastic anemia, as they're initially diagnosed, their blood counts often drop very quickly. So we've devised a trial as a way to try and intervene more quickly, because patients will know that they get diagnosed, people aren't really sure what's going on, they get bone marrows, they have to be sent to a big center. So there's often a delay in initiation of ATG or transplant. So this trial really involves, as soon as we suspect aplastic anemia, we start you on L-trombopag and cyclosporin, which are lower risk therapies than giving ATG. And we found that this may actually rescue patients' blood counts. So they're not dropping as much. So when patients actually do get admitted, their blood counts aren't as low, and they're not as likely to get complications. So I think that's one exciting development potentially. I already mentioned the additional TPO agonists. So I think expanding this will be important for patients, because if you don't tolerate one or one doesn't work, you can move on to another one. So it gives patients a lot more options. There's also been some work, and this is not something I'm directly involved in, using IL-2 receptor type therapies, and this is a multi-center study that I think is being run, primarily in Cleveland clinics. I think that's another thing for patients that they can consider. They had some really interesting preclinical data showing that that was efficacious. And then the final thing, we have a clinical trial also run using JAK inhibitors in aplastic anemia. So this is based on preclinical work showing that these can suppress some of the T cells that cause aplastic anemia, so the kind of lymphocytes that destroy the bone marrow cells, and also that the blood counts improved in this preclinical model, and this trial is running at the NIH. So I think, there's definitely a lot more options now for patients. I think transplant outcomes are generally improving. We have a lot more options for donors. And in patients who are transplant ineligible, the addition of these TPO agonists has really improved response rates. There's a lot more of those becoming available for patients who are intolerant. And then there's experimental therapies being tried, such as these JAK inhibitors and other things as well. So I think there are definitely more and more options for patients, particularly those who are interested in being in clinical trials. So I think if you're interested in clinical trials, one of your best resources is a website called clinicaltrials.gov. So this includes all the clinical trials in the US and many international as well. And there's actually a search bar where you can search by disease, and you can just type in aplastic anemia or whatever bone marrow disease that you have, and it'll collate all the trials that are looking at aplastic anemia. And you can also filter by region, country, whether it's recruiting or not, and different things. So I think this is a very useful resource for patients, and it usually has a contact information as well, so you can email that person.